Good afternoon. Thanks for having me. PK, I appreciate it. We'll get right on to this so we can move through. So going to give you a little bit of food for thought. There's a lot of data here, so I'm going to have 47 slides in the next 10 minutes. With that in mind, food for thought, is endovascular first always better? I think that's the big question, and probably the proof is in the pudding. The data is out there that says whether it's better or not, it's what is being done across the country and probably across the world. The good news for us is there's probably not a cookie cutter algorithm though, and even though like the best trial and other evidence-based trials are trying to say, oh, which should you do first? But the issue is that we have so many portions of that, and I'll go through that a little bit. Always use what is best, your best judgment and what's best for the patient, and not necessarily is just in your skill set. The person who's really good at distal bypasses but doesn't know how to do pedal access probably should not be trying to do pedal access. Likewise, the person who does pedal access but doesn't do distal bypasses, you get the point. So you can look for advice outside your specialty. So this paper is actually one I published back in 2008. But this was actually combination therapy. So this was the idea of taking care of folks who have below-the-knee disease but also have above-the-knee disease. But interestingly, to show that you could teach an old dog new tricks, we did interventions for above the knee, and then below the knee did distal bypasses, and we actually showed very good patency. So, below the knee interventions for do not have to be 100% endovascular, and we actually did these at the same time. I thought it was fun to see that this was revisited more recently, and there are numerous papers. They don't cite my paper from 2008, so I'm really heartbroken about that. But I think the important portion here is a lot of the below-the-knee stuff that we do, really the endpoint, and PK and I have talked about this extensively, the endpoint is actually wound healing, right? So we spent a lot of time talking about what's efficacious and is it still open and did this thing really work? But until the wound's closed, it's not necessarily closed. So this is the same idea as what we published about in 2008, where interventions were done for the SFA component, the CFA, the SFA, and it's sometimes the popliteal component, and then a distal bypass was jumped off of that. In this case, it doesn't really matter. The data is not so important, but 50-50, whether it's above or below the knee, it really depends on where your outflow vessel is. So this obviates the need for hard thinking, and I point out that the vascular surgeons in the group here, when we're not doing interventions, when we're doing bypasses, it's very easy for us because we just go from where it's good to where it's good, and then we put a good vein in between, and we don't have to worry about the atherectomy and the angioplasty, and was it a balloon, and was it a drug-eluting balloon, and was it a covered stent, and was it not a covered stent, and was it a drug? Just do a bypass. And so I think some of the people in the room who've had to train with me understand my theory. I'm like, heck with this, let's open the leg. And the other issue here, though, is that we have, but why do we do endovascular first? Well, the patients, very low risk. Usually the patients have no length of stay or one night length of stay. They have no procedural pain. It's always nice to have a patient say, so when do the stitches come out? No stitches. You can go home tomorrow. And they ever, and when can I walk? Well, when you go home, you can walk and you'll feel better. So there are a lot of good reasons to do endovascular first. Now, what's the big data say? And this is somewhat old. This is actually a paper from 2006. And this just shows that the reduction in distal bypasses. So I always point out that when I was, my first year in training, or my first year out of training in New York City was 2000. I did a true distal bypasses somewhere in the foot once a week. So I did 52 in the first year I was out. Now you do them like once a month, maybe. So the long and short is that by 2006, we reduced the number of distal bypasses in the country by about 40% and increased the number of percutaneous interventions. So as I said, the proof of it is in the pudding. Now, 20 years ago, in the previous century, most of these interventions were done by interventional radiologists, but that's changed, obviously. And as all the people in the room are quite aware, this is now mainly being done by interventional cardiologists and vascular surgeons. And that is just permeated further and further. And as more people are trained in these, endovascular first is going to remain the way to work. Now, I think there are some interesting questions. And one question would be possibly the age of the patient. Should endovascular first procedures be really reserved for older patients, and possibly patients have bypasses and then go on to intervene on them percutaneously later. And I think a lot of us with experience in the room have seen these patients who you even might say, I'm not sure why they got bypassed because I can get through this SFA, I can get through this popliteal, I can do this now. So we see more of this, and it might be an option depending on duration of therapy that we actually offer some of our younger patients. Because certainly the mindset is that people get endovascular first at age 58, you open an iliac stent, well, maybe they should have gotten a bypass and they get 10 years out of that. Of course, their survival remains a question. But should open be done first? One thing to think about. On the other hand, endo has definitely expanded some folks who once upon a time really had no option, right? I'd look at a patient, I'd be like, oh, you don't really have anything to target, you don't have anything. Well, now I'll try sticking the dorsalis pedis or posterior tibial. So certainly endovascular first for some of these things that you couldn't do before, or patients who have nothing in their foot whatsoever, and possibly venous arterialization, which I'm sure will be spoken about if it hasn't already been discussed today, but doing these procedures down to a vein and popping over from the posterior tibial. So there are things that we can do endovascularly that open did not allow us to do. But on the other hand, the big question is probably, does endo and endovascular first for critical limb ischemia, especially below the knee, does it burn bridges? So this is big data. This is looking at a California database, looking at 16,800 patients who were treated over an 8-year period between 2005 and 2013. And fundamentally, and this is obviously not randomized in any way, this is just looking at what happened. And what they took a look at was that about 1/3 of these patients had a bypass first and 2/3 underwent endovascular first. And what they really showed was that the endovascular first patients were actually more likely to have multiple comorbidities, as you see in the 4th bullet point. And then what was interesting is down and you get to the 7th bullet point is that open first surgery was associated with a higher rate of limb loss. But of course, this is not randomized and probably biased towards patients with greater tissue loss and possibly complications from their wounds themselves. So, not shockingly, endovascular first was associated with more reinterventions. But if you take a look at single center data, this is looking out of a group over just 3 years and just 215 patients or so. And I think a lot of you have seen this because this reference is actually cited quite frequently, is that patients who had undergone endovascular first, when they had a bypass as a rescue, they often did poorly. Well, I think this is actually kind of a funny paper because probably the reason that they needed the bypass was they didn't have good runoff. It wasn't that it was endovascular's fault. They were bad patient selection, right? They were probably patients who were predicted to have poor outcomes. So I think the problem of trying to figure out whether you should do first is going to be very hard to standardize and make it uniform across all patient populations. So there are some interesting thoughts on how you might burn bridges, and I don't think this paper outlines a couple of things that we do, and we know we do this. Well, we do disrupt plaques on purpose, and then we try to cover them. Now, should covered stents or stenting make a difference in distal embolization, et cetera, et cetera? Neoendomal hyperplasia, I think we worry about from barotrauma and balloon angioplasty, but we don't really worry about from wire manipulation. I definitely think there is some truth that sometimes we cover things that have collateral flow. And obviously, we've all probably been involved in cases where we have distal emboli that are a problem. So we can compromise our runoff. So I think we have to be aware that we're not making things worse when we do an intervention. And that we really, if it's a last-ditch attempt and we're really going to do something very funky to the dorsalis pedis and it's the only outflow vessel, you should at least be considering, well, should we do a bypass? Do we really have to do a retrograde access? If we really screw up this vessel, could it be a problem? Can we rescue it, et cetera, et cetera? So in closing, just talking about the efficacy of below-the-knee intervention, taking a look at what you do, and some people love atherectomies, and if you take a look at the data about plain old balloon angioplasty versus atherectomy, et cetera, it depends on who you're reading and probably who sponsored the paper to some degree. But that being said, this paper, what you keep seeing when you take a look at these papers is folks who undergo atherectomies tend to have less occlusions and more stenoses. I don't know about you, but it's been a long time since I've seen a tibial stenosis that I was worried about. They're almost always CTOs, and I tend to think the subintimal or intraluminal plain old balloon angioplasty is good there. So with that in mind, I think there's a lot of role for moving ahead with your below-knee interventions based upon what's best for the patient. I saw the laugh. Below knee amputations, and that's when those fail. You can always send those to me because you're not able to do those endovascularly yet. When you get the suction amputation device developed, then I'll be talking to you again. Anyway, thank you very much for your attention.